posterior. What does the posterior supply?
The muscles of the back.
Yes, the muscles of the posterior gutter and also the skin over that. And the anterior?
The epiphytic muscles. You know, the motor system, peripheral motor system.
Okay, so it forms the plexi, the anterior thing. So the plexus formation is from the anterior primary ramus. Now, when we talk about the thoracic nerves, we don't have these contributing apart from the upper part for the brachial plexus and the lower part of the thoracic spine to the lumbar plexus, but the middle part is producing that anterior branch that forms which nerve? Say to yourself quickly, this is advanced quadrant B course. So it'll come to you then. These are the intercostal nerves, aren't they? These are the direct branches of the anterior primary ramus. And what happens with those is two branches, isn't there? Superficial branches, the lateral and the anterior. So now we've got the posterior primary ramus is in the gutter here and the skin over that, which completes this here, and then the middle one here is supplying the lateral body wall, and the anterior will come out and supply this anterior in here. So we've got a complete ring of supply. All right? That's one thing. What else do you know about the cutaneous supply of the thoracic spine? How easy is it? Let me ask you it specifically. How easy is it to pick up dermatomes with the thoracic spine? No. Why? There's a lot of overlap, and so we've got one here, but it's overlapped totally from above, totally from below. Very, very difficult. What we notice much more, of course, in the thoracic spine is when we come down to this facilitated segment, the sensitivity of tissues when we do various stressing things over them. Right. On with your list. What else should we talk about? I mean, this has done the lecture. Thank you, Tony.
What about the ribs like the bucket handle and pump handle action and release?
Okay. If we look at the ribs, and we're going to not do that now, but that's well worth bringing up here. We've got the ribs, and we can perhaps divide those into a number of groups. We can talk about rib lesions from positional lesions, like posterior and anterior displacements, the bucket bale, and all those kinds of muscle energy things. But we can also look at those that are, and this is the terminology I would like you to use because it is totally straightforward. We can have an inspiration-restricted lesion, which means that the bone is held expirated. But if we say inspiration restricted, we know exactly what we're talking about. And we can have expiration restricted lesions. This would be a bone held in an inspirated, if there is such a word, an inspired position. But we'll use this expiration restricted, inspiration restricted, so we have no difficulty. If it's inspiration restricted, we've got to produce more inspiration movement at that rib. All right? Now then, if you're talking about the ribs, ma'am, just carry on.
Well, joint dysfunctions because of all the connections to the thoracic vertebrae.
Yes?
Costovertebral and the various joint dysfunctions that can occur.
Okay. Can I just be a little bit of a devil's advocate for a moment? An iconoclast, all right? And ask you the question, this question. All of these lesions that we've got, these positional faults and inspiration, expiration restricted and all of this thing, how does this fit in with the ligamentous joint arrangement of the ribs? Hey, anybody can answer this. I didn't want to put you on the spot. I wouldn't do that, of course. Any? But you're very much invited to answer that. I have a lot of trouble with all of these rib things. A lot of trouble. I mean, you look at, we won't do it right at this minute, we'll make a little deal of this for 15 minutes, but if you look at the number of ligaments and the attachments posteriorly of the ribs against the body of the vertebra and the disc and the transverse process, probably it's as good a ligamentous attachment as exists anywhere in the body. Which means that the movement that is so important with the ribs is really sort of well controlled. And so when we kind of talk about things coming out and going back, there's an awful lot of rib ligament damage and attenuation at the very least that would have to occur to allow these. I mean, just today, sort of let it go through your mind as we're doing other things. What are these ligaments? They are multiple for such a small bone at the back. But of course, what we have got, and we can speak about that just for a second now, is that arrangement at the back where we have the neck and the head of the bone like this coming out to the angle, and then the body of the bone coming around to the front here to fasten with the sternum. And we won't flog all the attachment points just at the moment. We can do that a little later today. But we know that small amounts of movement at the back are going to be reflected because of the length of the body of the rib here into large swinging movements laterally and at the front. So a small movement at the back through the system will reflect itself in large excursions of movement at the front. So consequently, a small restriction at the back can produce a large restriction at the front. I remember Greg Grieve once talking, when people are talking about all these multiple kinds of problems that go on with the ribs, and he kind of looked and he sort of opened his eyes. He says, he said, I think all you have to do is to just move the ribs about a little bit. However you want to do that. Instead of getting all sort of tied up with a whole lot of stuff. Great, you're doing well. Any other things that we should put up? How about diseases that might be very, very important in this area? Osteoporosis, okay? Why asthma? Okay, because it's related through its medication to the development of osteoporosis. Excellent.
Can change the capacity of the rib cage to move. The lungs are always expanded.
Okay. So we can get alterations in motion through some of these diseases, perhaps even going into the sort of emphysematous type of rigid chest. Okay? Any other diseases that we should be most careful of? Okay? Sherman's disease. The other name for this? Yes, or chondrosis. So osteochondritis, chondrosis, mostly which part of the spine? And lower, much more in the lower part here, okay? This particular thing here, Stoddard did a lot of work on, and he felt that it was a very, very prevalent disease. And this, I think, has been supported now. It is a disease, of course, juvenile osteochondrosis. It does change the shape of the bodies, and it perhaps sets up the spine for later degenerative changes. So osteochondrosis is a significant problem. All right? Any other diseases? Yes, or we could just put down tumors. And so we could, this is getting really messy, isn't it? Tony would be really pleased with us here. Tumors, and we can have primary tumors. Could you give me an example that is likely to affect the spine? Pankos tumor. Well, Pankos tumors, Apex of the lung, isn't it? Okay. How about multiple myeloma? This is the one that we really sort of think about. But of course we can also get metastases. And what I spoke to you yesterday that we should think about is any patient that has had a history of breast cancer, lung cancer, renal cancer, prostate cancer.
They will metastasize.
They're likely,
thoracic spine,
no, they're likely to metastasize to the spine.
not necessarily the
Not just no, not as far as I know. Funnily enough, the ones that I've ever seen that have metastasized have all been the thoracic spine, but I don't know that it is specific to that. Okay, anything else?
Pleurisy?
Yes. Why?
It affects breathing.
Yeah. Okay, I think that what I would like to just say, having you said that, it brings up another thing that perhaps we should think about, is that in the thoracic spine we get what Greg Grieve called in a lecture that he gave in Cambridge the masqueraders. In other words, we got diseases that seem as if they are causing dysfunction of the thoracic spine but are from elsewhere. So with a pleurisy, for example, you breathe in and it looks as though you can't continue the breathing in because of the pain. And so, okay, here we've got a musculoskeletal problem. It's affected by movement. But it's the movement of the lung and the covering of the pleura, of course, that stops the breathing. So it's one of these things where our basic rule, if it's a musculoskeletal problem, it must hurt when you move it, doesn't fully fit. That's good. Any other diseases? What's the great stiffener of the spine? Ankylosing spondylitis. Okay. And what do you know about ankylosing spondylitis and the gender relationship?
No, females.
It's certainly much more prevalent in females than it was originally thought. The pattern might be slightly different to men, but I think now we realize that this disease is much more prevalent than originally it was thought. Certainly in the Scandinavian countries it's very prevalent. Whether that's because they notice it more and it comes to mind and they treat it, I don't know. But certainly with this diffuse interstitial hypostosis, or whatever the modern terminology for this disease is, there are various manifestations of this. And certainly we know that one of the early tests that we would do for ankylosing spondylitis, if we see lumbar spine restriction both ways, very great stiffness in the morning, is to look at the respiratory excursion. And anything less than perhaps 1.25 inches or 1.5 inches should be kind of looked at, probably. So these are considerations. Great, so we've got another disease in here, ankylosing spondylitis. We've got the masqueraders, which I'll speak about a little bit later on. Any other problems here? Let's have a musculoskeletal problem here, as a disease, if you like. How about disc diseases in the thoracic spine? Not particularly common. Generally in the lower part of the thoracic spine, but the real significance of these things is the narrowness of the neural canal. And so they can threaten the neural canal. I'll speak perhaps a little bit later just on thoracic disc lesions. Just very few points, but just to sort of focus you a little bit. Anything else that we should speak on? Our board looks pretty good. Now you can all then put all these things down in the sequential notes to make you feel comfortable.
compression fractures, because we see a lot of that in the spine.
Okay, what levels? More lower, isn't it, in what you see, where the sudden flexion and a fall. I guess this depends on the industrial sort of areas that you have and what happens. We used to get a lot in Britain because I was brought up in a sort of a mining community with very narrow coal seams. You know, people used to work like this all day. Unbelievable when you think about it. Okay, so fractures. Now, are there any signs which, these obviously here would focus us into a problem, not necessarily a pathology. Some of these things might not cause any of these to change. So we have to be aware through our questioning and through our observation skills that some of these things aren't necessarily going to produce a threat to the spinal cord themselves, but they are intrinsically a threat to the thoracic vertebra. And so we have to sort of try and marry up from our questioning and so on these things with signs. So because we see the signs are okay doesn't mean that we're automatically free and dry. On the other hand, we don't want to sort of make this so that it is so complicated that we're sort of scared to treat most people. How many of you see very many thoracic spine problems? Yeah. How much of your practice would this constitute?
40%.
40? Oh, that's pretty good.
Well, when you figure its effect on shoulder girdle and
Yeah.
neck or
Yeah, yeah. So in terms of those you have to treat, it might constitute 40% of what you're treating. The thoracic spine in some way is involved, and you have to make some contribution to its treatment. You know, I would say in my practice it's at least a third. What I find that I have to be very careful of is, oh, here's a thoracic spine, I can get in there, I just move it around, let them go, and I can catch up with this big long list. And that's not good enough. We've really got to think that this is a complicated area. It's a great challenge. But the great thing is that we have such magnificent treating techniques that the world's got to be waiting for us to get out there and to show these things, because they are just excellent. Anything else that anybody feels we just really ought to put on this list?
cardiac kind of problem.
Okay, we could perhaps put this in the little group of referral into, referral away from, and the sort of somatic cardiac things. So that would come in here. Thank you. Any others? Okay, what would be the effect of good? We could put this up here, primary curves and the effect of structural changes. And how is that going to affect, you know, things like coupled movement? Is it even possible to sort of assess in a consistent way anybody that has got a structural change? Perhaps we are satisfied by trying to just look at the movement and not try and work it out too much in terms of what all the coupling is, because the coupling has been fundamentally changed. Great. Any others? I'm going to sit down and put this on my list, all these things.
Clinically, I don't know how I would pick it up, but Schmorl's nodes, and I'm not sure how involved it is in the T-spine, but just... something that I've learned, but I don't know how I would pick it up.
It's an aspect of Sherman's, isn't it? So these things, it's also an aspect of central disc problems, but as disc problems are relatively rare, I think that Schmorl's nodes that we find in the thoracic spine are nearly always a manifestation perhaps of Sherman's disease. Yeah. But Schmorl's nodes are a common occurrence, and I think that, is it because that part of the spine did have osteochondrosis, or is it the sign of early central disc prolapse, which I think is far more common, the early compression strains of childhood that cause problems. But then, of course, it's in children. Have they got the growing pains? The growing pains, perhaps in some cases, perhaps insidious Sherman's disease.
So is it more common in the thoracic spine than in other?
It's common in the thoracolumbar junction area, yes, and that's where Sherman's disease is the most prevalent. But you can get it in all sorts of areas anyway, but I think that's related much more to, in other areas, perhaps to early compression, damage to the disc and damage to the end plate. Great. So let's get that down here, Schmall's nodes. Yep, anything else? Or is this just about done it? Yes, Anne?
Potential for instability is in the thoracic spine.
Let's put that somewhere to do with coupling. And when we think of instability here, what are we kind of thinking of? That we haven't got many degrees of freedom, we haven't got many degrees of movement. Not degrees of freedom, of course, is the same as in all the rest of the spine, 6 degrees of freedom. We've got, when we think of instability again, we're thinking of translation. We're thinking about the support given by the ribs. So it's not as common perhaps as in other areas, but it's certainly something that we should not ignore. I don't think other people would perhaps pick this up too well, because I'm not sure that X-ray studies on the thoracic spine really pick any of this stuff up. Have you? So it's really a very sort of feeling that we have, which is very difficult to give to, orthopedists and so on. And anyway, what would they do about it? This is why I think sometimes we get really tied up with like instability of the alar ligament. Is anybody going to do a fusion of the craniovertebral area because of an alar ligament laxity? No way. They would for a transverse ligament laxity. So, so if we find it, perhaps we are the only ones that will recognize this to any great extent. So perhaps what we do is just say it's there. Nobody's going to do anything about it. Nobody can do anything about it except us. So we'll do what's necessary, which is to protect it when we treat it, to try and get a muscle balance thing going, and to start giving lifestyle changes that the patient can do. These are the things. And so in the thoracic spine, what would we do? We'd look around it, we'd try and move any stiff areas and try and teach a pattern of management. But your system here, and certainly our system in Canada, does not lend itself well to treat instabilities. You go to Norway and people go for a year of treatment. This is treatment within a centre to start with, and then go from that centre, usually of which has a physical facility alongside it and part of that facility, and then they work out in these very specific ways in that facility. But people here, being paid for by your external medical plans and by our government-run plans, it doesn't run itself to a year of treatment. You couldn't, the plan wouldn't pay for it. And as our compliance rate of exercise is abysmally low, what is it, 10%, 15%? Very, very low. Then this is a major problem. I'm not sure that we recognize it. We have great treatment techniques, but I don't know how successful we're ever going to be with all this. All right, anything else? Not bad. I've kept you going for an hour when you all looked blank when I gave you this little thing. So this sequential, or not sequential, but just this random thinking and the way that, things interrelate. And if I got another color here that I could find, we could go back and we could interrelate so many things. And this was what's good about this kind of random thinking, because that's how our brain brings stuff up. Not like this, that's how we learn, and we want it all listed down in that sequence. But our brain doesn't work like that. It keeps grabbing bits and pieces from all over the place. And coming in here, we've got all sorts of little things, wondering how your children are, and all kinds of little things that keep coming in and wondering, and wondering how your clinic's going on, wondering if they can manage without you. You know, what you're going to eat tonight. All these things keep coming in. It's like having lots of files all open in your computer, and things are going on all the time. And so this is a really good way, I've found, of just thinking about, what do I know about this subject? And it really is surprising how much you know if you sit down and let yourself freewheel for a while. And it's quite comforting to do this. So when you're reviewing stuff and you think craniovertebral, what do I know about the cranial? Get it down there and just think. And once you've got a heading, I mean, you can think through, what do I know about that? Okay, that's that good. Now go to the next thing. Very, very good and comforting to do this. Now, what I would like to do is this. I'd like to have a fairly simple approach to the thoracic spine and gradually get a little bit more complicated. I'd like to introduce, for example, the principle of using combined movement for locking when we're dealing with big levers. And perhaps if we get really kind of technical, we can kind of lock from above and lock from below. But we'll get on to that, and we'll go from the very specific techniques of individual bone movement onto the more complicated techniques of using larger levers. And if we can get hold of that principle, it makes the next step, which is the manipulative procedures, fairly easy. Now, while it's in my mind, and I would probably forget, and I tried this out on Diane Lee, and actually she didn't think it was too bizarre. And I also tried it out on Stan Paris, because what I've been trying to do is to think about the problem of why do women have more problem with manipulation than men? To learn it and to do it. This is a kind of a universal observation. Why is it? Is it to do with strength? Doubtful. Because when you see women, if you watch Anne manipulate or Diane, all of them can manipulate. But there is a problem teaching women to manipulate. And what we need to do is, on courses like this, at this level, say, can we identify why there is a difference so that you can perhaps practice? Now, perhaps it's going to change in the sense of, I think many of the sports that men were involved with were rapid, combative sort of sports. Well, women are doing all that stuff now. But we've always done it. And all our sports have been hit and stop and bang into somebody. And, you know, the idea was if they were stuck there, you wanged into them and hit them out of the way. And that's how we were brought up. But women never were. What did you do? You did more the rhythmic, flowing kinds of movements, and that's not explosive, sudden movements. So that's one thing. I think there might be a psychological reason here. How dare I talk about women's psychology? But here I am. Let me try it. I think men are much more likely to look at a conflict, see it, and hit it head on. They don't care. That's the way that we sort of address problems. Just bash in there.